Thank you, Dr. Holder. I am Gilles Clermont from the University of Pittsburgh, Critical Care Medicine. And the purpose of this talk is to discuss guiding principles for data harmonization and standardization in critical care, and to report on an effort that was conducted as part of the data science campaign at SCCM on coming up with some guiding principles for harmonization and standardization. This actually started from a vision a little bit less than 5 years ago, and I would have to say really shortly before COVID struck. We were actually still in Milan when we had that first meeting and barely escaped the COVID wave when it struck Milan. But that idea of the importance of data sharing and using the current wave of data science was actually put forth then. This actually gives you the genesis of that data science initiative. So after a joint venture, essentially between SCCM and the SICM, to build what could the next 5 years look like in terms of data science campaign, the SCCM Council in May of 2022 launched a data science campaign. And that data science campaign had the following mission, which the ultimate goal was the application of data science in clinical environments. And the vision was really to enhance knowledge, advance research, and improve outcomes in the critically ill. So it was really critical care focused. And there were three main arms of this data science campaign. A first domain, which focused on large-scale data harmonization and sharing. A second domain, which is to build a data hub within SCCM and the hosting of datathons. Within that first objective, we sought to establish guiding principles for data standardization and sharing. The field was probably not mature enough then to come up with actual best practices of how to do this, because everything is still pretty much in turmoil. But guiding principles, that was definitely doable. So the guiding principles could actually be useful to frame how you plan data collection, how you assemble it, how you prepare it for sharing, and how you extract knowledge from data gathered at many different sites, still fulfilling the unique needs of critical care medicine. The steps that were taken then is actually to put together a panel and conduct a systematic review, followed by a modified Delphi process and consensus, and finally dissemination. And I'm happy to report this is exactly where we are today, at the dissemination point. Importantly, the guiding principles for data sharing and harmonization have to cover the entirety of the data life cycle, this series of circles here, from even conceiving the next data collection, the generation of data, all the way to essentially when you destroy the data. So this is really what that data life cycle is. And from beginning to end, what you can see there is that it is very closely linked, but it's not, with the data science life cycle, which is the building models, analyzing this data, and so forth. So we're really focusing on that top sequence of events, which is the data life cycle, because it's necessary to actually come up with healthy principles governing this. So the panel on data sharing and harmonization consisted of 34 experts from a variety of domains, as you can see here, and was divided into several working groups under a steering committee: conceptualization group, review group, validation group, and finally a Delphi group. So 3 phases of this effort consisted of conceptualization of how this would work, of the project, and then a preparatory research phase, and then the Delphi panel phase here, as you can see. So in the conceptualization phase, we took those elements of the entire data cycle, included in there what we call age seed manuscripts of, things that we believe as a panel were also already very important contributions. And we actually generated a pretty extensive literature search yielding about 8,000 manuscripts. From these, we sort of screened the 8,000 manuscripts, and 700 or so were actually retained for full text review by 2 reviewers. And finally, out of those 773 manuscripts, we extracted 322 prospective statements. That's a whole lot of guiding principle, and we can't stay there. We have a lot more work to do. So this is where we sort of pass the baton from those 322 to the conceptualization, to the validation group. And therefore, we entered the second phase of this. So from those 322, we actually ended up categorizing them along different themes of interest and extracted, after much consolidation and validation, on acceptability, importance, and feasibility of these prospective statements into 24 guiding candidate principles that we could actually put forth to the Delphi group. So I want to talk about about this thematic analysis. So from the 322 to the 24, there were clearly 6 domains that actually came out from common data elements, harmonization, quality, the infrastructure, governance, and ethics were actually 6 themes that were recurrent, and that were sort of the umbrella under which those guiding principles were put forth. So the Delphi group included several additional experts not in the original review group. The first 2 rounds were conducted offline, and that led to a pretty extensive reformulation of those 24 principles. 19 of them was pretty extensively remodeled, mostly to simplify them, and they ended up looking like this: a short descriptor followed by what the actual principle is, and don't worry, we won't go through each of them like this. So we did hold a consensus meeting just a few months ago, and a manuscript was just published depicting the results of the Delphi process. I wish to underline that the themes cover the entire data life cycle. So the 6 themes I just talked about intersect many of the different steps of the data life cycle, and this is both important and expected. And the manuscript was just out last week, and I do not want you to read any of those 24 principles right now, but suffice it to say that within each of these themes emerge 2 or 3 principles that will actually frame and guide the future, or our future interaction with the data that we can actually read or collect or plan to collect or analyze. So what are the key take-home messages, and why should we care about this? So as I said, the guiding principles span the data life cycle from collection planning to data destruction. They're not unique to critical care, and they should not really be unique to critical care, although critical care is abundantly emphasized in the guiding principles. They move across the age span, so they pertain to neonates, to the elderly, and they're also multi-stakeholder, meaning that they're important for clinicians, they're important for industry, they're important for patient advocates, and essentially, they're essentially pertaining to a lot of people that contribute to this data enterprise. They are strongly ethically and governance based. So this is actually a very important aspect of those principles. And I would actually would like to add that there are sufficiently flexible to allow for regional differences. We try to put forth principles that will actually endure several years. We don't know. This is a rapidly moving field. Maybe we have to repeat this in 10 years' time, but most likely not in 2 years' time. So these are pretty foundational, and they serve as essentially a framework for best practices or best practices to be put forth. I would like to acknowledge the co-chair, Donna Armagnac here of the PDSH, and Dr. Heavner, who's actually been a moving force with this, with the PDSH. The leadership of the PDSH as well, Mr. Mannion, Dr. Mannion, Handel, and Remy, SCCM support, Tamara, and all members of the panel. I think we will hold for questions till we have this, sort of all speakers come on the scene and have this session at the end. So thank you very, very much for the opportunity here to present this.
Thank you, Dr. Clermont. So again, I want to remind everyone that we are going to hold questions until the very end. I neglected to mention that earlier. So we're going to jump straight to our next speaker, which is Dr. Karin Reuter-Rice. And she'll be talking about C2D2 and common data elements. Thank you.
Thank you very much. It's a pleasure to be here, and thank you to the organizers for inviting us. So I'm going to jump off, except I don't know where my slides are. Hold, please, for technical help. And present now. Yep, that's me. Thank you. Thanks for your help. All right, here we go. I have no conflicts. And these were the objectives that were put forward in the presentation materials. I'm not going to spend a lot of time on them, but just know that we're going to overall across all three presenters hit on these. Okay, so just a little framing, because I think sometimes this can be convoluted for individuals who have not been part of this process. And that is, you have the society as a whole, you have Discovery as the trials network, then you had this data science campaign, which then embraced a data outcomes and definitions group. And then you had the domain one, which Gilles so eloquently touched on, and you might see that slide again. But you had the C2D2 working group, and I'm going to dig into that a little bit more. You've seen this. This is the same mission, so thank you, Gilles, for putting it up there already. And then again, you see these three domains. And what I wanted to touch on these domains and why domain one was so important for us to really think about these strategic steps that we took is that there really are limitations to data, right? The infrastructure of data, the heterogeneity of data, cost, interoperability, reusability of data. And so I think this was really the passion behind those that came together to really talk about how we can use better, how we can really construct an infrastructure where data could be very useful. Okay, so just briefly on this slide, I think what I want the takeaways to be is really the motivation for the development of common data elements is focused on critical care research, trials, and quality improvement. And I think that what was probably the most important part is that there was this consensus of a large group of individuals that said, we really need to develop CDEs within critical care. All right, so you saw from some of Gilles' explanations of how their team worked. Our team had a similar type of process where we, brought together a group of subject matter experts from many domains, and I'll show you those shortly. Basically from Congress of 22 to Congress of 24, where the work was conducted. And we had some developmental steps, really a comprehensive list, and I'll talk about that in a sec, really pulling together the right people to be at the table, and then importantly achieving some consensus and overall consensus with having a document that we could share, not just with our society and members and the public at large, but more importantly, to start framing the type of work we'd like to conduct. And we used a modified Delphi process to achieve this. So our work group was composed of 23 individuals. I will just share with you that of those individuals, we had, of course, clinical researchers, we had bench researchers, we had quality improvement people, data scientists, and clinical informaticians. And I think what that allowed us to do was really harmonize the idea about what is the importance of CDEs and how do we best tackle this. So in our group, and thank you to Dr. Murphy, who established an IRB at Emory for us, to start the Delphi process. And you can see here that we had multiple rounds to achieve this, but I will tell you a little bit about the preparation work before we actually fully embraced ourselves within the Delphi process. And that was, we used some existing CDEs, and those were from Virus, PrEP, and ICERIC. And we had 1,833 candidate variables to consider with 19 domains and 125 subdomains. And I'm going to walk us through a little bit on how this shaped out. All right, so we had our strategy, and that was looking at some core data sets, which I just spoke to, and thinking about what does this look like across the lifespan. And why is that important? Well, one, because we had representation on our work group across the lifespan. We had neonatologists, we had pediatricians, we also had geriatricians, and those that practice adult critical care. And we really felt it was important that there would be CDEs that could translate across those populations. Importantly, we also wanted to make sure that we were encompassing CDEs, even foundational, at the critical illness, but also at the injury level. Next, we really saw our purpose as being able to determine adequate and valuable resource utilization of these CDEs, so not just building something that was so highly customized that it couldn't have real feasibility across many different platforms, and then importantly, thinking about how does this inform patient outcomes. We also considered characteristics. How feasible was it to actually use these CDEs in different type of critical care settings? Thinking about whether or not we could see project-specific outcomes using these CDEs, facilitating both manual and electronic, and that comes back to thinking about settings. You know, in lower resource settings where they may not have the electronic capability, could they still participate in using the CDEs to drive data? And then really real-time capture, thinking about that in the spectrum of care, and thinking, of course, the use of this in an electronic health system. So our attributes really contained 4 tiers of item categorization. So we had the high domain level. So if you think about this as being clinical assessment. We had a subdomain level, which were a smaller group of variables that might sit within clinical assessment, like blood pressure. And then the conceptual variable, so a specific measurement like a mean arterial pressure, and then what would be the common data element? How did we define that? What was the framework it sat in? And then how would we be able to measure that? So think about this, the lowest mean arterial pressure in the first 24 hours of an ICU admission measured by a cuff. All right, so here you can see what I spoke to a little earlier. We had on our initial round, we had 19 domains with 125 subdomains. At our next round, we actually increased a domain and we added more subdomains. And then in our very final round, we whittled it down to 9 domains and 36 subdomains. And you might ask, why did we not continue to keep the expansive domains and subdomains that we had? And we really started thinking about burden of collection and practicality of the use of these CDEs, considering this is version 1.0, and more importantly, the access and use of it across many domains. So in the end, what you're able to see here on the slide is that you'll see that we have our domains, our 9 domains, with a total of 226 final common data elements that sit within these domains. These domains, again, cross the lifespan, and we were really pleased that we were able to actually accomplish that, even though that was our core mission. So that was a kudo. In the end, I think another really important piece for all of us who think very importantly about outcome, and it can't just be mortality, but really thinking about data elements based on disease and severity scores. And you can see here, I'm not going to read out all the different severity scores, but overall, we had 181 of our common data elements cross all these severities, so about 80% of them will actually have at least one disease severity score attached to it. All right, so takeaways from this, really establishing the first comprehensive critical care data dictionary, which we fondly refer to as C2D2 because it's too long to say it over and over again, was really thinking about the range of the individual CDEs, importantly what our populations were and could we truly feasibly use them, were they focused to the ICU patient, and then importantly as well, how do we use them beyond the individual element? So could we actually use them across our disease severity scores, and then the manual and electronic capture? Some limitations worth considering, and I think these are important to point out because there is never any perfect study or any perfect process. And that is, these need to be formally validated. We need to know whether they're feasible and whether they work across settings. Our core mission was to make that happen. Now we need to test that it will. Remember that these are not exhaustive. I've kind of alluded to this is 1.0. We expect there to be a 2.0, a 3.0, and more. And importantly, thinking that now this is the springboard for future cassettes, whether those are subspecialized cassettes for different type of diseases or different type of organ system dysfunctions, or whether they're within different populations, so expanding in neonatal, pediatric, geriatrics. And then importantly, thinking about the linkages to broader structural and organizational characteristics and making them relevant. So how do we evaluate whether or not these CDs can accomplish some of these things? So our next steps, particularly within the data science campaign, is a validation process. And what that'll include will be a pilot within the electronic health record. We'll be looking at some pilot applications. I think the call will go out after Congress if Vishaka can verify that. And then thinking about the integration of the C2D2 into more modernized techniques, and then expanding it to our global partners who you'll hear from shortly. So hot off the press, this was released on Friday. I'd like to say kudos to all of the work group, all of the members who so diligently looked at draft after draft after draft, and here we have it. And it's been a labor of love, but one that we're very excited about. Last acknowledgements. This is like climbing Everest. You don't get there alone. I'd like to shout out to my dear colleague, Dr. Karin, who was in the trenches the whole way. Couldn't have done it without you. The C2D2 work group, particularly Dr. David Murphy and Dr. Wes Anderson, who really between their sophistication in modified Delphis and data informatics and data science really led this charge for our group. Importantly, staff of SCCM, Dr. Vishaka Kumar and Dr. Tamara Al-Kahim. Without them, we never would have gotten off the ground, so huge shout outs to them. The data outcomes and definition colleagues, that's Dr. Clermont, Dr. Armaniak, and others who, always were touching base to make sure that our harmonization and the principles and what they were working on actually had relevance to what we were doing, and so thank you to them as well. The Discovery Group has a beautiful organization where they have a review committee. They looked at our manuscript and gave us some thoughtful feedback and thumbs up. The Oversight Committee, led by Dr. Khanas and Evan, really the support to move the project forward, Council for its approval and funding, and then, of course, the journal editors for pushing it out in time for Congress. And so what I will do is I will stop there, and I will turn over the mic to our dear colleague from the World Health Organization, or maybe Dr. Holder will be doing that. But I hope you'll enjoy Dr. Wallis's video.
Thank you, Dr. Reuter-Rice. So again, as we mentioned, this is not just an SCCM effort, but it's in the context of a broader global initiative. So with that said, I'd like to ask Dr. Lee Wallis to speak about the WHO registries. So Dr. Lee Wallis will be presenting that virtually, so we're going to get that set up. So give us a couple moments to do so. Thank you. Actually, we're having some technical difficulties here, so I'm actually just going to invite those speakers who've already spoken to come up while we try to get that last virtual session organized. And at this point, I'll actually open the floor to any questions that the audience might have of those who've already spoken. All right, well, seeing one person coming up, while that person makes their way to the mic, I'm going to, I'll actually ask the first question. So we talked a lot about these data models, these guiding principles. Who should be the stakeholder in that? Who is the person to, or who are the people to initiate those processes? Are we talking about researchers? Are we talking about hospital systems? Some kind of governing body, perhaps the federal government? What is your vision of how these different processes might work once we put these plans forward?
Well, I think the different stakeholders all have a genuine interest in having this work. What we've seen, though, is that there are existing data models. EPIC has one. MIMIC has one. Cerner has one. They just don't talk to each other really well. And it's hard to actually, for those of you that do EHR research, for example, it's really hard to actually navigate from one system to the other and make sure that a blood sugar is a blood sugar is a blood sugar across all those systems. So I believe that this is from the researcher aspect, but you can also look at it from the insurer's aspect. How can you make sure that the processes that happen in hospital A are the same that happen in hospital B? And this is what motivated the RGs and so forth. So I'm thinking there are all the stakeholders have an interest in having us have a data lingua franca, so to speak.
Thank you, Dr. Clermont. I'm going to go ahead and ask the first person to identify themselves and also ask your question or comment.
Yeah, hi, my name is Falk von Dinklage. I'm from Germany, and I'm a member of the steering committee from the European Societies and the German Society for Data Standardization in Critical Care. And my question would be, how far along are you in the further standardization process in terms of technical interoperability and semantic interoperability? Are you exactly defining fire profiles or using OMOP semantic concepts, like to bridge the gap between the different data standardization concepts, like from EPIC or somewhere. Like we need the standards, like HL7, fire, or OMOP, or whatever. So we're currently struggling in Europe with discussing what are we using. Are we looking more at OMOP? Are we looking more at fire? Or are we looking more at OpenEHR? That's our main question.
So the guiding principles have not chosen winners yet. We are definitely mentioning OMOP as an exemplar structure that people could use, or FAAN if you're thinking real time. So we certainly are recommending that you should be looking at those means of harmonization and standardization. Definitely people that will look at those principles have chosen winners yet, and we'll see what happens. But so we're not, the effort was really not at that level, but to set the stage for that level.
Thank you very much.
Dr. Cobb?
Good morning, everybody. So in response to the gentleman's question, important question, the data science campaign does have a complementary investigative initiative called Acquire, Accelerating Quality Improvement in Research. It's in the form currently of a NIH R01 proposal that's supposed to be under review this coming Thursday. It's been submitted under review. God willing, thank you, Karin. The NIH will still be funding science moving forward. So in that proposal, what we will do, we're doing it more on the, not so much the investigative side, but the performance improvement side, is partnering with the new Centers of Excellence program, which you heard our president present this morning, and mapping those elements. It's a small number, about 20 or 30 elements, to OMOP initially, and then FIRE. We're assuming that most of the OMOP mapping will be done at academic medical centers, because mapping to OMOP, as you know, requires a fair amount of standardization and resources locally, whereas FIRE is not. So by the end of year 4 of the proposal, we're expecting to be able to map the Centers of Excellence data elements for quality to OMOP and FIRE. And there would be an opportunity for us to take, now that it's been published, C2D2, and have that be the complement to the Centers of Excellence data elements. And if anybody's interested in working on that, we'd be excited to. Yes? Yeah? Okay, good.
I think I see one more question. And then we're going to pivot a bit and we have the person, Dr. Ellis, who's going to be giving that talk virtually. He's actually on the phone right now while we're getting that uploaded. And we can open that up for questions to him directly so he can answer that. Video's up? Okay, perfect. So we'll take that one question, and then actually we'll go straight to his talk about the WHO registries. Thanks. Thank you.
Hi, I'm Nadich. I'm in pulmonary critical care at the University of Pittsburgh. I actually had a question about VA research, which is one place where I think that data standardization practices would be really useful, especially when it comes to critical care research. I'm not sure if that's being considered in this whole really important process, and I'm wondering if I can comment on whether it might be something that you consider in the future.
So has the VA chosen sides in terms of they've chosen CERN, or have they chosen OMOP as a standard data model?
They have their own, if anyone's done VA research, I think it's all over the place, and actually and you have to go through multiple different programs in order to find the actual vitals, so it would be one place where I think it would be really useful.
Omar will talk to it.
Yeah,
You want to talk to it?
I could just answer that question real quick that you had. So at the Defense Health Agency, they have landed on OMOP as their final common data model for all of their electronic health record data. So they're in the process of building that out and having a unified process for queries across the VA and Defense Health Agency.
Thank you, Omar, and you heard it here first.
Excellent. Okay.
So actually, I am going to ask one more question. So there are likely going to be growing numbers of data that will be added to either the EHR or some data lake that could be used for analysis, predictive modeling, et cetera. I'm thinking of things like septicite, for instance. Are there ways that the C2D2 can accommodate those new data forms, whether they're already in existence or things that we have not yet found or not yet used, to apply to C2D2 and to apply to critical care research in general?
So I'm going to take a stab at this, but Karin might have some thoughts on it as the co-chair. I think the C2D2, as it's been currently developed, is really the launching place for those next steps. I'm not sure that there's another session here where you're going to be really thinking about the use of broader data. So thinking about waveform data, thinking about other data that we capture that really at this point in the CDE is not been taken into consideration. While we may have some basic data elements that will relate to those waveforms, we don't actually have any translation for them yet. So I hope I'm answering your question,
Yeah.
Andre? Okay.
Yes, thank you.
All right.
Did anyone else want to touch on that? Dr. Cobb?
I might.
I like to use the analogy of I'm sorry, Gilles, go ahead.
Go ahead, sorry. Gilles.
Well, that was as a follow-up to Dr. Reuter-Rice's comment, right? So by all means, go ahead.
So I like to use the crawl, walk, run analogy. Part of the reason to focus on as limited a data set as it is, right, given the universe of critical care data, and my dear colleague Eric can speak to that with the Chorus initiative, is that we need to be able to pick a level that everybody be comfortable with, right? So currently, if you go to a community hospital, they're not talking OMOP, they're not talking fire, right? They said we can have a research associate or a medical student or somebody who has the bandwidth to be able to enter this for a single patient for a given study. And that was really our starting point. We also know that if you want to look globally, certainly, right, the OHDSI is working on OMOP and fire as international standards, but there are so many hospitals across the planet, right, from a global health standpoint, that aren't going to be able to meet that anytime in the near future. So being able to have something that we could enter by hand, if you will, through a database made a lot of sense. So start there and then move out. But we're very interested in working with Eric and his team and hearing more about that.
Hi,
Thank you. We'll
everyone.
take one
Can
more
I have
question.
one more question?
Yes.
It's a little bit out there, but I'd really appreciate your input into this. This was wonderful, and for someone my age, this is like all revealing. I mean, it's new, it's exciting, and as many of you were at the lecture this morning on AI, and I just wonder, how do you envision this integrating with AI in the future?
This is foundational. I presented a slide here so there's sort of a data step from conception to destruction, this life cycle, and having a healthy data life cycle allows you to build models that mean something, and to build this layer of how do you help people, how do you augment knowledge in a more trustable fashion, in a more equitable fashion as well, because as you've heard, one of the things that those models do is that they may actually recapitulate what actually you find in data, which may be biased in different ways. So I think having those guiding principles out and having a list of data elements that people collect germane to critical care is sort of a foundational to this effort that we've heard about this morning. A lot of it is still, it's really, really, lots of hype, very intriguing, very interesting. A lot of it actually works, and it's going to change our practice.
Yeah.
But I think it has to be built on good data.
Good data, exactly. Thank you, Gilles.
So we are still having some technical difficulties with that virtual session, so If there are any further questions, again, the floor is open for questions or comments from the audience.
Just a quick question about, I saw the slide with the number of individuals per specialty, and there, you know, to oversee a committee like that, it's hard to have so many people, so you can't have, you know, 9 cardiologists and so forth. But there were a lot of N of 1s.
Yeah.
So how do you move beyond the group, the publication, and have public comment come from societies that themselves have hundreds or thousands of members, and then make the process of the building the data elements be iterative?
I think it's a really good question, and I'll tell you why. I'm going to go back to you have to start somewhere, right? And there was a lot of effort between ESIMC and the society to really acknowledge that we needed to start somewhere. And I think what you're seeing now is the translation of that start somewhere, and then what are the next steps. You know, I believe we will get public comment. I do believe that we have started some really nice relationships, and I think Dr. Kumar could speak to that a little bit more, not just with the World Health Organization, but other organizations who are really interested in partnering in both the use of the CDEs, but of course the escalation and elevation of what needs to come next. So, you know, it's a great celebration today, but we know it's the very first day and there's more work to come. I think that overall, I would say, while there were N's of 1, we were incredibly fortunate to really have talent at the table. The people who stepped up with having what I would consider very full baskets of their own made time for this, and so we really benefited by this really rich subject matter expert, whether there were 1. The interesting thing is when you look across the actual number of individuals, they hold multiple positions and have multiple talents. And so while one may be a clinical researcher, they also may have a background in data informatics. While some may have been data scientists, they also might have been clinical researchers. So while they represent as a 1 from a certain discipline, they have multiple skill sets that they brought to the table. And I have to say, honestly, they shifted their hats really quickly to try to get to the, you know, get to the good, instead of being the rate limiter, but really get to the good. And that was one of the strengths, I think, of the work group, is you could probably fold up your tent and go home pretty early, because this is hard work, and not one of them wanted to stop. And so you saw how many rounds we had. Initially, we thought 3 rounds. We had more than 3 rounds, and that was because of the real, I think, depth, but of the discussion and the importance of it, but importantly, the subject matter experts bringing their best to the table and saying, we really do need consensus and refinement in what we're doing. Mm-hmm. So first step, but I think, you know, certainly we're available for public comment, so bring it on, like help us grow.
Yeah, just one example would be that when you showed the severity scales,
yeah,
you know, SOFA, I didn't see, and maybe it flashed very quickly, a neurospecific assessment of severity. So that could be the Glasgow, or it could be the NIH stroke scale, or, you know, could be the ICH or FUNC score or something like that.
Yes.
So what would be the opportunity to sort of enrich the set when that eventually gets disseminated?
Yeah, so 2 comments to that. Like, we really did try to hold ourselves to thinking strategically around Apache 3 and 4 for severity, because it has a lot of common data elements. You know, it gets a little tricky when you start having neonatal and pediatric as well. But importantly, the other thing that you mentioned was, these are the reasons we're thinking there is going to be a build of a cassette, because you may only get a couple of common data elements that may be demographic in nature, but really they don't speak to the disease or the specific organ dysfunction you're going after. That's the cassette that needs to be built next. I think How we built it is going to be really rich for those coming forward who want to build next cassettes. The processes we put in place and how we came to them, I think would be really nice roadmaps. They can be refined, of course, over time, but I think it's a nice exemplar of how to at least accomplish the first C2D2. But I'll let Karin maybe have a thought on that as well, as co-chair.
Adam has been waiting for
Oh, okay.
Sure.
Well, thank you. Adam Layton from Johns Hopkins. And maybe this is a question best for Dr. Wallis if eventually he's able to join, but I do a lot of work in the global health space. I work closely with a group of intensivists in Addis Ababa at St. Paul's Hospital in Ethiopia. And I'm wondering about the feasibility or the scalability of this core data elements to a global health context. Are you envisioning this something that would be feasible to implement in academic centers or in community centers and LMICs? Or do you think that's going to be a next modification to build off of this U.S. appropriate core data set to be something that's feasible in more resource-limited settings?
Yeah, I appreciate that question, because really when we started this, we were very conscious of the fact that we wanted this to have applicability. While the request from Council came for US-based, we, sitting at the table, realized there was global translation, but we needed to make sure that when we developed that, it really could have some global translation. So, having colleagues that are in Zambia and in the Congo, could they use this? You bet they could use this. They could do it manually, they could do it in a red cap. I mean, it really is very appropriate, because the data elements are not at a level of such sophistication that they couldn't be applied to a global community. Importantly, and I'm hoping Dr. Wallis will come on and join us, one of the real advantages of coming at it from that perspective allowed the World Health Organization to ask whether or not they could use it for their critical care registry. And to us, that's a huge you betcha. They've established an MOU with the society, and that is going to be the framework for their registry for critical care. So there's already that global translation that they will be able to collect data using the C2D2.
Great, thank you.
And also, by the way, Dr. Wallis he's on the phone, so he was hearing the question. So I do have an answer from you from Dr. Wallis as well. He said the WHO Clinical Registry is built on DHIS2, which is a system used across IMIX systems, or IMIX settings. So it is deliberately designed for that setting. The data set that SCCM has worked on can be applied in that setting. And he also wanted me to let everyone know that there's no online option to join.
Oh.
LMIC setting, excuse me. Low and middle income country
Would
setting.
also like to add that among those guiding principles that we put forth, the question of feasibility was specifically addressed, and therefore there is a prioritization of what aspects of data health you want to establish first, depending on regional considerations. And so I think this is a very important element that we need to address proximally.
Yeah, I'd also like to respond to Eric's really important question. So this is the opportunity for us to leverage the society, right? Mm-hmm. There are sections. There's the neurocritical care section, right? There's the pediatric critical care section, anesthesia, surgery, emergency medicine, et cetera. There are a bunch of them. And one of the things we could do, is Vishaka had to go? Where's Tamara? There she is. Okay. One of the things that, and as the co-chair, I'll do a mea culpa for any problems there are with version 1. But one of the things that we could do at the society level is leverage discovery, right, as a multidisciplinary group, and reach out to the sections and ask each section to formally comment on version 1 of C2D2. Mm-hmm. And my guess is that they'll have a lot of comments, and you could create obviously a mechanism by which you could get feedback and then include that. I think it'd be great if version 1 didn't survive the first year or two, right? And we already started working on version 2.
So one other question?
Very simple question. How should a common consumer look at the C2D2 dictionary?
I'm sorry, could you repeat that?
How should we as clinicians look at the C2D2 dictionary? Is it accessed on SCCM, or is there a link to it? How should one search through it, and what are the guidances to using that dictionary?
Right now it's in publication, and the supplemental material will have actually all of the common data elements that you can actually access, so whether that's online or hard copy paper form. The Society has been looking at a data hub to look at what kind of cloud-based data platform could be used, like a RedCap account, where you could get access to a RedCap account where that's already built with all the common data elements in it. So that it would be very useful, particularly for trainees who don't have a lot of funding to, start collecting data and using a common data model, an element that would be then translatable maybe to a colleague who's at a nearby facility interested in the same type of work. I think there's some scalability to multi-sites using the same type of data, but like Karin said, it's the first level. We are hoping it will continue to be broadened and accelerated. But as far as access goes, the papers come out, the other mechanisms we'll have to share with you in the future. But it's forthcoming.
So since there's no one else at the mic, I'm going to go ahead and ask a question of each of you. So Dr. Reuter-Rice, you mentioned that one of the next steps would be validation. And I wonder what outcome or outcomes would we be looking at to say that the C2D2 is validated?
I think I'm going to scale to very broad outcomes, and those are feasibility. Can it actually be used? I think one of the goals with the pilot project is to see whether or not it can be used within an electronic health record. There's been some discussion of whether or not we should be testing that manually as well. I think there will be some, and Gilles can speak more to this, but thinking about using this in an electronic health system means that there's going to need to be a lot of IT infrastructure support. And what are the facilitators and barriers then for individuals who want to use this in that type of structure where every health system has their own rules. So I do think feasibility is a strong one. I think whether or not the definitions we've prescribed to the data element actually are the correct definitions. And then, of course, what's missing. And there's a lot that needs to grow in that field. So.
Thank you. So what I'm hearing basically is that some feasibility metrics,
right,
as well as, what are the things that might be missing, some percentage or accuracy would be another one perhaps in terms of
correct,
whether we're capturing what we actually want to capture. Thank you. And then one other question to, the video's ready? Okay. So we'll be running a little over, but I think we can go ahead and start that. So thank you everyone for your patience, and we'll go to Dr. Wallis, who will again talk about WHO Registries. Thank you.
So I'm the lead for emergency and critical care at WHO headquarters. I'm very sorry not to be with you today. I was hoping to be there, but I am connected via WhatsApp, so hopefully if you have any questions, I can answer real time. I'm going to take you through WHO's approach to the use of clinical registries, and particularly critical care and our relationship with the Society of Critical Care Medicine. So for those of you who don't know, the United Nations and WHO are both member state organizations. That is, the 194 member states tell us what our work should be. We're the secretariat for the member states. And we're given that work mandate through a series of decisions and resolutions. And while there have been a number over the last few years that have related to emergency, critical or operative care, surgery or anesthesia, the one that we're currently working under that has a very powerful mandate for the next decade or so is 76.2, you can see at the top of the screen there, on integrating emergency, critical and operative care with two functions. The first is to strengthen day-to-day health service delivery, and the second is to allow countries to be ready for and respond to large-scale emergencies like pandemics or conflict. And that's been supported by a decision that mandates that we develop a global strategy and action plan. Inherent in both the resolution and the global strategy and the action plan will be the need for data and the need to use clinical registries, both for system planning and design and for clinical quality improvement. As a organization, we have multiple different pieces, but on our side of the house, which is universal health coverage, although we have a very strong overlap into the World Health Emergencies Programme, we take a sort of three-basket approach. One is universal health coverage policy and packages, so the services that should be available at different levels of the health system. So at a first-level hospital, what critical care services should be available, and therefore what equipment, what medication, and what training follows suit. Pathways, how patients move up and down the pathway and through the health system. So a critically ill or injured patient, what should happen to them to get the best, most appropriate care at the earliest opportunity. And then improving clinical outcome at the point of care. And that's where the rest of the 7 or 8 minutes will focus. So we have a number of resources across emergency, critical, and surgery and anesthesia care, and we have a number of partner structures to support implementation and measurement of these. So we put these in sort of 6 broad areas related to what I've already mentioned. The important thing here is on quality of care, we have standardized clinical forms, we have the establishing quality improvement program, learning program, and resources, and then we have the clinical registry. But just to stop here for a moment and mention the acute care action network, as our 3 networks that are centered in our unit, the acute care action network, SCCM is one of the earliest participant organizations in that, and it's about implementing and measuring WHO's tools on acute care, of which the clinical registry is one of our key ones. So the clinical registry, we actually started it just before COVID as called IRTEC, the International Registry on Trauma and Emergency Care. The trauma module was developed and then rollout was stalled by COVID. So we had a fresh start in late 2022 and we repositioned as the clinical registry. And while we have not finished all the modules yet, when this is all done, we'll everything from primary care through to definitive care. So a primary care module, emergency care, trauma, sepsis, critical care, and operative encounter modules are the ones we're currently have under development. So the value of this, like most clinical registries, being embedded into the clinical setting so that you can identify these targets for quality improvement interventions, and both that and for those who have access at the sort of aggregated data level, you can set priorities and you can redesign how services are provided to meet changing patterns of illness and injury. So there's 3 parts to our registry platform. The one is standardized clinical forms. The next is the data sets that underpin. So like the C2D2, data set for injury and the data set for emergency care and the data set for the operative encounter module have been developed through robust processes. And then we have the clinical registry platform. The platform is housed on DHIS2, which we house, we pay for, we maintain. All that sites who are using the registry platform need to do is have some Android or laptop device to enter the data and someone who can actually enter the data. Everything else is at our cost, which for those of you involved in clinical registries, I'm sure you know, after implementation, the biggest problem to sustainability is the ongoing costs. Standardized clinical forms, of course, I'm talking to an audience that would mostly use electronic records, but in many, many parts of the world, records are paper. So we have not done this yet for the critical care setting, but in the emergency unit and pre-hospital environment, we have 2-page standardized clinical forms. The importance of this is not really to know about those, but that we have deeply integrated the clinical registry data set into the form. So the yellow highlights there, for instance, are the trauma module data set. So when you use this form to record a trauma presentation through the emergency unit, for example, you can then extract the data easily into the registry platform. And we want to follow a similar sort of model for the critical care registry model. Dataset for injury developed over a multi-year period with multiple partners. WHO's quite slow at developing technical products, apart from in emergency response situations. But the reason we're slow is that we undergo a really robust global process with a very, very wide range of partners, which means that when we bring tools out, they are incredibly powerful. Ministries take them very seriously, and it allows scale up of implementation. So this has 46 core variables and 28 extended. The core data set has been added to for the data set for emergency care. Slightly more variables, including triage, pre-hospital time, and the pre-hospital provider. And then the operative encounter for use in the operating theatre, it's got 29 core variables and 12 extended. And this is the sort of thing that you would see if you were entering data in this example on the operative encounter module. It takes you through a series of free text and drop down. We try to keep the free text to a minimum so that the data dictionary can be used. As much as possible. And then we've already got built-in visualizations, which would vary if you're using it as an individual provider. You might get patient-level data, but those seeing aggregated data would not. And we have inbuilt audit filters. So I'm telling you all of this, not necessarily so you go off and use the registry, but we want to follow this same process for the critical care module. So what's the data set? What are the core components that should be in what forms extended data set? And then what are the dashboards that both clinicians would need to see and policymakers? And then what audit filters should be in place? So an example of an audit filter here on the emergency module is all emergency unit patients in the highest triage category. So that would be red usually. And the time that their time from arrival to the first provider is over 30 minutes. That is a quality improvement trigger. And then you can pull up all of those cases and screen them for quality improvement opportunities. We are really dependent on our partners, more so now than ever at any time in the past, unfortunately. We are hoping that we can use the data dictionary that has been developed by SCCM and very generously provided to us to engage with a wide range of stakeholders and agree the core data set and extended data set. And we're going to be having discussion with FCCM and other critical care partners about taking that forward now. And just as an example of the development of the data set for emergency care, after a long period of iterative work building consensus, we rounded that off with an Utstein meeting at the Utstein Abbey in Norway, where we reached consensus on all of the components. The reality is, though, despite these nice data sets and registries, we have to be suitable for purpose and this is the reality in operating theatres around the world. So we need to keep this in mind when we are planning these out. And just to mention that I said equip, the data, the clinical registry is a really key component of our establishing clinical quality improvement program bundle. So there's a learning program in there on the WHO Academy platform, and then there's a number of tools to support quality improvement activities. I will leave it there. Sorry for running a minute or two over, and good luck with the rest of the panel. Thanks.